Hello, everybody. This is me, Dr. Sergio Rovinsky from Shoulder Planet, here from São Paulo, Brazil. I am very honored to be participating here from Wiroc, this lovely meeting organized by BOSS, Bombay Orthopedic Society, and I invite you to see all of the videos that I have sent to this wonderful meeting and to learn the most you can with them. And if you have any doubt, don't hesitate in sending me an email. My email is sergio@shoulderplanet.com.br. I thank all of the organization of this lovely meeting, and I hope you have fun seeing all my videos, and Dhanyavad.
Massive rotator cuff tears are the most difficult kind of rotator cuff tears to be treated, and for many years, open management has been indicated as the best method of treating those lesions. Anyway, arthroscopy has been evolving a lot in the recent years, and nowadays, even massive rotator cuff tears can be well treated arthroscopically. So this case is about a 68-year-old woman who had a massive rotator cuff tear in her left shoulder. And in this photo, we can see an MRI coronal view in which we can see that she had a quite retracted lesion of the supraspinatus. And in this other image, we can see an MRI T2 lateral view in which we can see that she had a massive tear of both supra and infraspinatus. So this is her arthroscopy. This is the left shoulder. We are establishing the anterior portal using a spinal needle and opening the capsule with a mosquito. Now we are performing a very fast synovectomy underneath the long head of the biceps, and then the biceps was tested. And as we pulled the biceps out of the pulley, we could see that the biceps had a lot of fraying and synovitis, and since the patient was very symptomatic, we decided to perform a biceps tenodesis. So now we are just cleaning the rotator interval, and with a spinal needle, we passed a Prolins number 2 suture through the long head of the biceps, and now with a suture grasper, we are just pulling it out of the shoulder through the anterior portal. And since then, with the biceps whip stitch done, we just had to perform a simple and fast biceps tenotomy. So now the biceps tenotomy is being finished, and then we would just have to perform a very fast debridement of the biceps anchor, and then we would have to go to the subacromial space. So now we are working for the lateral portal, removing all the synovitis underneath the acromion, and when the bursitis was removed, we started to see the tendon, and now we are just seeing the tendon and cleaning the bursal leaders in the posterior part of the tendon. We can see that the patient had a very big lesion, as we had already seen on MRI. And now we changed the portal, so we're watching for the lateral portal, and for the posterior portal, we're cleaning the bursal leaders in the anterior part of the tendon, and we can clearly see the biceps whip stitch. Now we are cleaning the posterior bursal leaders. At that moment, we decided that we would be able to fix the lesion, so we changed the portals to perform a simple acromioplasty. So now working for the lateral portal, we are releasing the coracoacromial ligament, and once the coracoacromial ligament was released, we would just have to perform a very fast and simple acromioplasty. So working for the lateral portal, we are performing a standard acromioplasty, and once the acromioplasty was finished, we would have just to look at the tendon. So now we started to clean the tendon using a simple grasper, working for the lateral portal, and we are removing the tips of the tendon because we know that they are quite devascularized. And now we are cleaning the anterior parts of the tendon too, and now the posterior part of the tendon. And once the tendon was totally cleaned, we started to create a bony bed in the greater tuberosity, working with a soft tissue shaver. And now we are just cleaning the greater tuberosity to create a bony bed. And once the bony bed was created, we used the spinal needle to put the first anchor in the very anterior part of the greater tuberosity. So now we unloaded the first anchor because only with one suture we thought we would be able to perform the biceps tenodesis. So now we're using a simple suture passer. We passed the Prolene number 2 suture through the long head of the biceps. And now we are pulling this Prolene out of the shoulder through the lateral portal. And in a retrograde fashion, we pass it, the first part of the blue suture, through the long head of the biceps. So now the suture is being passed, and we just have to repeat the procedure again. So now both parts of the blue suture were passed through the long head of the biceps, and at that moment we would just have to tie a simple knot to perform a biceps intra-articular tenodesis. So now the knot is being done, and once the knot was done, we would just have to cut, and at that moment the biceps tenodesis was done. So then we changed the portals again. Now we are watching for the lateral portal. That was really a massive lesion, so we started to release the lesion from our adhesions of the glenoid. And the first thing we decided to do was to perform a lateral knot passing through the medial part of the posterior tendon. So we passed a bird beak, passing the white suture that was removed from the first anchor. And in the same way, we passed that bird beak for the anterior part of the tendon, and in a retrograde fashion, we pulled that white suture out of the anterior portal. So then we would have to pick the two parts of the suture, the anterior one, and then the posterior part of the white suture, and pull both of them out of the portal, and then the lateral knot would have to be done. So now we are tying the knot, a simple slide and Duncan knot. Now the knot has been tied, and once the knot was tied, it would just have to be cut. Now the knot is being cut, and at that moment, with a single lateral knot, we understood that the tendon was in a much better condition. So then we changed the portals again, and now watching for the posterior portal. When working for the lateral portal, we put a second anchor in the very posterior part of the greater tuberosity. So now we are putting another 5.0 absorbable double loaded anchor. And once the anchor was in a good position and firm, we used the Express Seal device and passed the white suture for the very posterior part of the infraspinatus. So now we are passing the white suture through the posterior part of the infraspinatus and just pulling it out of the shoulder with a simple suture grasper. So then the knot would have to be tied. Now we are tying the knot, putting a lot of compression under the tendon. And once the knot was done, we would have just to cut it. And then working for the anterolateral portal, we repeated the procedure using the Express Seal again, passing the blue suture of the second anchor through the transition of the infraspinatus with the supraspinatus. So in the same way, we would have just to pull that suture out of the shoulder with a suture grasper, and then again tie another knot. So now the knot is being tied, and once the knot was tied, we would just have to cut it. So now the knot was cut, and at that moment we changed the portals, and now for the lateral portal we could understand that the anterior part of the tendon would still have to be fixed. So we cleaned the very anterior part of the greater tuberosity, and at that moment we put a third anchor in a very anterior part of the greater tuberosity, just behind the biceps tenodesis, and then we passed the suture the blue suture again, and we would have just to pull that suture out of the shoulder in the same way with a suture grasper. And then the knot would have to be tied. So with a cannula for the lateral portal, we tie that knot. Now the knot has been tied, and once the knot was tied, it would just have to be cut. So now the knot has been cut, and at that moment the surgery was finished. This is the final construct viewing for the lateral portal. This is the supraspinatus, and we are seeing now the infraspinatus, and now we are seeing the biceps tendon. This is in the anterior part of the humeral head. We can see that a very strong construction was done. And now as we internally and externally rotate the shoulder, we can see a very strong fixation of the infraspinatus, now with a white stitch in the very posterior part. And now we are seeing the blue stitch of the infra and supraspinatus, and another blue stitch of the supraspinatus. And as we externally rotate the shoulder, we can see again the articular biceps tenodesis.